Good evening, everybody.
Good evening.
Thank you. So welcome to our 15th program of this year. Hard to imagine. Yes, 15th program, we're only in the middle of April. It's a good thing. Last year we did 31 programs the entire year. Here we are only a quarter of the way through the year, and we've already done now half of what we did all of last year. What does this mean? It means there is a great demand for what we're doing. There's a great demand and many audiences that keep contacting us and asking us to do programs in their area. Last year we did our first program out of the state of Florida. We went to Atlanta, Georgia. This year we're doing 3 programs so far out of Florida. Last week we did Birmingham. Next weekend we're doing, in 10 days we're doing Charlotte, North Carolina. And then in June we're doing Atlanta, Georgia. We have programs, and we're waiting to set up programs in South Carolina, and now today we were asked to go to Indianapolis, of all places. So we're going to be putting in a program to do an event in Indianapolis, Indiana, hopefully by the end of the year. So again, though, what is this all about? It just means what MS Views and News does. We are something different than any of the other MS organizations. We're providing a specific need for the patients, and that is to provide you with education and allow you to learn more about the disease and learn how you can learn about the different medications that are available, A to Z, everything, not focusing on one medication. And that is who we are. So, now going a little bit forward. We want to thank tonight EMD Serono. They make Rebif. We'd like to thank them for giving us the grant to do tonight's program, and I do thank them, and I hope all of you do as well. In addition to EMD Serono, our other sponsors for tonight are Accorda Therapeutics, who makes the Ampera, the walking pill. Bayer Healthcare, who makes Betaseron. Biogen IDEC, who has Avonex, Tysabri, and Tecfidera. Then we have Genzyme, who produces Aubagio. Aubagio is one of the oral medications that I hope that you're hearing about. Then we have Questcor, who makes Acthar Gel. And for those that don't know about Acthar, you'll be hearing about it tonight's program. And Teva Neuroscience, who has Copaxone. So, and by the way, for those that don't know, Copaxone's out in their new formula as well, so you may want to hear about that from the doctor too. So without going any further, sorry for my words here, tonight's program format, we have Brian Steingo, neurologist out of Broward County, Florida, who will speak first for about 50 minutes. If you didn't see the agenda, it's on your table. He'll be speaking for about 50 minutes about current and emerging therapies, adherence, dietary, and self-help aspects. It's 2 new topics that you haven't heard about. Then we'll have Dr. Valerie Mastin. She's a neuropsychologist from the local area, and she'll be speaking about the impact of MS on the family, MS in relationships, starting a family. She'll be speaking for approximately 35 minutes. After the 2 of them speak, we'll do a Q&A. So we do hope that you'll hold off on all questions, write them down. Write it down on the back of whatever you have there. Write it down or send yourself a text message in silent mode, so that way you remember what you want to ask later on. Okay, so without any further ado at this point in time, let's ask Brian Steingo to come on down as he drove up from Broward County today. Thank you. Where's the pointer? That's a good one.
The pointer's on there. I just want this thing out of here. Okay. Well, good evening, everybody, and welcome. And thank you for coming. And a special thanks to Stuart for arranging these meetings, which you've heard how many he's done. I think they're very important because I know in this area you have many pharmaceutical company sponsored programs which are limited somewhat by the FDA. You're talking about a specific topic. But in a program like this, we can talk about many different topics to do with MS. And I've tried to put in some topics. As Stuart said, I have 50 minutes. It's hard to just limit talking about MS and different topics in 50 minutes. So at some point, Stuart will wave to me, and then I'll have to go and sit down. But I hope some of these topics are new to you, so you can see some new things, and others will be revision. There we go. Okay, so this topic that I've called the land of MS. So all of us here tonight can consider we're in the land of MS. When you have a diagnosis of MS, you're initially shocked, surprised, stunned, all kinds of things like that. And I came up with this name for the land of MS. I looked up different titles. Everyone on the internet has taken up MS World, the World of MS, all these things are taken up. But the Land of MS, nobody else had, so I came up with this title of the Land of MS. And when you have this Land of MS, these are all the different topics that we could spend each one of these hours talking about. So we could, for example, talk about how do we diagnose MS and what kinds of MS are there. We could spend a long time talking just about that. Most importantly, we could talk about drugs that are used for MS, and there's two groups of medications we could immediately talk about, which is how do we treat a relapse? And what disease-modifying drugs do we use for MS? So you remember those used to be called the ABC drugs. The first one of those is almost 21 years old. 1993, beta-serum was the first drug approved. May 1993, birthday next month. And now we have altogether 11 different agents that have been approved by the FDA for MS. So we could talk about those, and we could talk about symptoms of MS. And why do I call that the symptom tower? Because how many symptoms of MS are there? Many, that's right. So that's why in this land of MS, the symptoms are managed in the tower. It's a skyscraper, because there's many different symptoms, and we could spend all night talking about the symptoms. And some of them we will briefly talk about, but there are many symptoms of MS. And then we have medical support, which means other than your neurologist, who is the captain of your program and working with you, you might see an ophthalmologist or a urologist or a psychiatrist or a psychologist. There could be many other people involved with your medical support. And then social support, most important, social support. Could be from family or friends or from the MS Society. Very important what kind of support you have. This to me almost is like a support group. Sometimes you come, you meet new people, you meet different people, you can socialize a bit, you learn a little bit, you eat a little bit. It's a whole bunch of things that you can do when you go to a support meeting. And most importantly, self-help. And without self-help, the whole thing kind of will crumble to the ground. What you do for yourself is important. I'm going to spend a lot of time talking about that, because that's a subject that people don't often talk about. You often go to meetings where they talk about the drugs and the symptoms maybe, but I'm specifically going to talk about this topic as well. I think it's an important topic that is so important and often not addressed. Oh, okay, let me populate this. So I'm going to start off over here and talk to you about what is MS. And we know that MS is a disease of the central nervous system. The central nervous system is the brain and the spinal cord. But it's an autoimmune disease. So the primary problem in MS is not the brain and the spinal cord. The primary problem is the immune system. There is an abnormal immune system which is triggered off and then attacks the brain and the spinal cord. So the target in MS is the brain and the spinal cord, and the trigger is something in the immune system. If the target was the joints in your body, you would have rheumatoid arthritis. If the target was your thyroid gland, you could have Graves' disease. Diabetes, type 1 diabetes is an autoimmune disease. So depending on the target is the disease you have, but the trigger is something going wrong in the immune system. We don't know what triggers off the immune system. We'll get into that in a second. So you can see I've put here some triggers. Genetic factors. So we know that genetics seems to have some importance in MS, and there are many genes involved in MS. There is not just one gene type. It's very complex. If there was one gene, it would be simpler to identify and diagnose. But there are many genes involved. But there are also genetic factors in MS. If you have MS, other members of your family have a higher risk for developing MS too. So there's definitely genetic factors and genetic susceptibility. So what you have is a person who is genetically susceptible, and then other factors come into play and trigger off the MS in that person. It could be environmental factors. It could depend where you live. You know that people that live in northern latitudes in the US, in North America, or in Europe, people who live in northern latitudes have a higher risk for MS. It could be infections. One infection we definitely know that seems to be a trigger is mono, and there probably are others. So these are some of the triggers over there. There are probably other triggers, such as vitamin D deficiency. And I'm going to talk a little bit more in length about the importance of vitamin D in MS. We could spend a whole hour talking about it because it's so important. So now you have a genetically susceptible person that's exposed to these triggers, and it triggers off the MS. Acts on the immune system. The cells in the immune system are called T and B cells. They're a form of white blood cell. They're a part of the immune system. Did everybody see what just happened? Did you see that? Did everybody see the arrow hit the target? All right, we'll go back. So the immune system is activated. So here you've got an active immune system, and you've got a brain over here that's the target, and these cells in the blood have to cross something called the blood-brain barrier. It's a barrier. And that's actually how some drugs for MS work. They work at the barrier to close it. So these cells, when they're activated, can't get through and attack the brain. So here, now I want to alert you all to watch this. In 1 second, you'll see what happens. Okay, so that's what happened. The immune system got activated, and the dart hit the target, which is the central nervous system. And some drugs can't close that off. So now the target couldn't get through. That was my own creation, by the way. One night late, when I probably had too much to drink, or maybe too little. I'm not sure which it was that night, but. All right, so here we have a summary of what is the sequence of events that happens in MS. So we said there are triggers in a genetically susceptible person. You have triggers that activate the immune system that attacks the target. And what's the first thing that happens in the brain or the spinal cord is you get inflammation. And the inflammation attacks the myelin around the nerves and results in demyelination. So we call MS a demyelinating disease because the inflammation as its first target attacks the myelin. But there is also an early attack on the axon. So the axon is the actual nerve fiber. And when the axon is attacked, and if the axon is destroyed, it cannot recover. When the myelin is damaged, myelin can recover to some degree. If it's inflamed and damaged, there can be some recovery if the inflammation subsides and goes away. But the axon can never recover. And if the axon is damaged, that leads to atrophy, shrinkage of the brain. Therefore, this is one of the reasons why we want to treat MS early. When we make a diagnosis, in most people, we're going to recommend early treatment because we want to prevent this whole sequence of events from happening. This shows you, this is just a slide. This is a piece of brain tissue to show you what inflammation looks like if we look at a piece of tissue under a microscope. And what you see here in the corners is normal brain tissue. So in the top left and right corners, you see normal brain tissue. But look what you see right in the middle over here. You see a blood vessel and millions of lymphocytes around it. That's what inflammation could look like if we could actually look at it. So this is just showing you an inflamed area of the brain. If you looked at this on a scan, you would see a bright white spot on a scan. It would tell you this is an inflamed area. So that was really the introduction to what MS is, what we think about the causes of MS, some risk factors, leading us to know that we should treat early to stop the inflammation and the progression of the disease. I'm going to talk about self-help now. And there are two acronyms that I have to remind you about things that you need to do for yourself. This is one of them I put up here. You can look at this. All these, as Stuart says, these are all going to be on YouTube. So I won't belabor this one because this is my new version of self-help, the things you do for yourself. And I called it a team of friends. This was another one of those nights when I'm not sure whether I was, maybe too much of the good stuff or too little or something. But here, team of friends. So if you think of this, if you just remember team of friends, you say, what are the things that I can do for myself or that are involved in my care where I contribute? And so T was temperature. So we know that people with MS are heat sensitive. This sequence, of course, is arbitrary because once I had the things I wanted to include, I had to kind of make up the words. So this is not the sequence of most important things. But we know that for some people, temperature is very important, that if you're overheated, it can aggravate your symptoms. Right? Whether you get into a hot tub or you go outside in the middle of the day or whatever happens, or you have a fever, you get sick, you've got an upper respiratory infection, urinary tract infection, you've got high fever, and guess what? Your temperature goes up and it aggravates your symptoms. It can make your blurry vision worse, it can make your weakness worse, it can make your tingling worse. Your symptoms can be aggravated by temperature. This is important also in terms of the medications. We'll talk about that a little bit if we have time. Expectations are important. That means when you start a medication with MS, any new medication with MS, it's important that your physician explains to you what we anticipate from the medication. For example, you start a new medication and you come back and see a neurologist 3 months later and you say, I started the medication X 3 months ago and I don't feel any better. And 6 months and 12 months go by and you say, I don't feel better. Well, that's good. Because what is MS? It's a progressive disease. It can progress. You can have relapses. So if you feel the same, the medication is working. So expectations are that the purpose of this medication is to do a certain thing. For example, it might be to stop you from having relapses and stop your disease from progressing. It's not necessarily to make you better. So a disease-modifying drug is to stop the relapses and stop progression of your disease. And then what we do is we get off the elevator and go to the symptom tower and now improve the way you feel and your quality of life by working on the symptoms. And very important, adherence. You need to take your medications. Does that sound, well, that's obvious. Well, guess what? The compliance rate is bad. People don't take their medications as prescribed. If it's an injection, they get tired. Or they say, well, I don't think it's working. Or they have side effects. You need to discuss those with your neurologist. Or they have a pill that they have to take twice a day and they say, I think I'm feeling good, once a day is enough. So adherence to the prescribed dose is very important for all medications. And then the mental aspects. There's many of these. How do you manage memory problems, cognitive problems, mental stimulation, your mood, depression, anxiety? These are common issues that we have to deal with in MS all the time. Mental aspects are very important to be discussed and to be managed. And sleep. How many people with MS complain of sleep problems? And this is complex. Sleep in MS is not just, doc, I can't sleep. All right, here, take Restoril, then I can get out of the office 15 minutes earlier and go home and watch the Miami Heat playing or something like that. No, sleep is complex. Why are you not sleeping is my question to you. Why are you not sleeping? Well, I don't sleep because I have spasms that wake me up. Oh, okay. Well, I don't sleep because I go to the bathroom 5 times at night. All right. Now we're getting down to it. I shouldn't give you temazepam for your sleep when you go to the bathroom 5 times a night. I need to address your bladder problem. So these are complex. We need to look at what's the reason, what's the underlying reason why you have a sleep problem. But that said, they have recently published a study where they evaluated people with MS, and they found that a high percentage of people with MS actually had sleep apnea. So there are things that give us clues to that. For example, it's more common in males for one thing, but if you have snoring, you are at a higher risk for sleep apnea. If you have hypertension, you're at a higher risk for sleep apnea. And sleep apnea itself is a dangerous thing because there is a higher risk of strokes with sleep apnea. And, strokes actually are a little more common in people with MS. It's not bad enough you get MS, you have a higher risk of strokes as you become an older MS patient. So sleep is very important. And then an outlook, a positive outlook, that would go with the mental stuff to some degree. And then there's fatigue, which is very important also. And when you come in and you say, I have fatigue, again, if I'm in a rush to get out, I can say, okay, let's try amantadine, let's try Provigil, let's try Ritalin, and I'll see you in 3 months. Or I could say, let's see why you're fatigued. And why could you be fatigued? I'm not sleeping well at night. So there could be other reasons for fatigue. I feel depressed, I'm not sleeping well, I just started taking a new medication, and this medication, look at the side effects, drowsiness. So again, with fatigue, we need to look at, are there underlying causes, and not just to blame it on MS fatigue. So once we've eliminated those, we might say, okay, now we know why you're fatigued. We need to treat the underlying causes. So first thing we're going to do is we're going to send you over to the symptom tower, deal with your causes, and once we've done that, then we can do with primary MS fatigue. Oh, how did that happen? Okay, more items over here. Food. I'm going to talk a little bit about diet and dietary aspects. Relationships, that goes with support groups. Obviously, the stronger your relationships, friends, family, good news, and interactions. All these things are related, and that includes in a group again. Exercise, very important, and everybody can exercise. So in my office, I have a little booklet that's called Seated Exercises. It's for people that can't stand or who get tired when they exercise for long. I say, these exercises are no excuse exercises. Everybody can do them. Move whatever you can move. Keep things moving, whatever you can do, even if you do 5 minutes at a time. Everybody should be doing some exercise. And then keeping in touch with the news. And there's all kinds of news, fortunately, on the internet. There's an organization called MS Views and News. Some of you have heard of that. It's an essential part of what Stuart has done to get this news disseminated to us is very important. And sometimes there's a lot of it. And you don't have to read all of it. Read whatever you can. You could get news fatigue too. But everything is there that you know when you look at it. And if it's relevant to you, take it to your doctor and discuss it. And here I put as a whole separate section, vitamin D. So I think vitamin D is as important as everything else you do for MS. And we're going to talk a little bit more about the importance of that in a minute. And finally, smoking. So that doesn't mean I'm encouraging you to smoke. That means smoking is bad for MS. And multiple studies have now been published showing that people that smoke have a greater progression of their MS. There are at least 3 studies now that have been published showing smoking correlates with MS progression. So we have things over here that correlate with MS progression on this very slide. Vitamin D deficiency equals MS progression. Smoking equals MS progression. Lack of exercise equals MS progression. So look at things that you are able to do for yourself that could help you in some way. I've called this slide over here defensive nutrition. It's about healthy eating. So whether you have MS or you're the partner of someone with MS, I think this is healthy eating for everybody, which is these facts over here. And I'm going to go back into some of them again, which is the importance of breakfast, because what does our brain function on? Glucose. Our brain needs glucose to work. And you need to feed your brain early on. You need to eat regular meals. We'll talk a little bit about fat, important fats, the importance of plants, keeping yourself hydrated, helping certain problems such as bowel and bladder management. And then the most important 2 supplements. Obviously, if you go on the internet and look for supplements for MS, there's 100 different things you might find. But the most important 2 are these 2 over here. Vitamin D that we're going to talk about in more detail in a second, and vitamin B12. So vitamin B12 is a very important vitamin for the nervous system in general. So if you have a condition like MS, where you already have your nervous system under some pressure, it's very important to make sure your vitamin B12 level is also up to par. And these are the plants. I quoted at the bottom here, this comes from Joel Fuhrman. Some of you seen Joel Fuhrman on PBS? Or seen his books? I mean, just listening to him, he's excellent. And he talks about the importance of eating all these plants over here, the colored vegetables. I think he calls this combs, C-O-M-B-S. Colored vegetables, onions, mushrooms, berries and beans and seeds. That this should be a substantial part of your diet. Unless you have some allergies or something like that, this should be a substantial part of your diet. And here is vitamin D now that I'm going to spend a few minutes talking about. So many people now consider that vitamin D actually could be labeled an immunomodulator. So what does that mean? All the drugs we talked about right at the beginning, the disease-modifying drugs, modify your immune system. They're immunomodulators. And some people think that vitamin D is equally an immunomodulator that actually has actions in the immune system. So there are vitamin D receptors on the surface of cells, and they are widespread in the body. So you always know about take calcium, take vitamin D, it's good for your bones. But vitamin D is much more widespread than that. The vitamin D receptors are widespread in the body. There's many other actions, including there are vitamin D receptors on B and T cells. You remember we talked about B and T cells before that are part of the immune system, and on the surface of the B cells and T cells are vitamin D receptors. And let's go over here. So vitamin D acts on the vitamin D receptors, and in order to be fully effective, we have to saturate these receptors. We want them filled with vitamin D. And to do that, you need a level of 75. So if you look at the normal range of vitamin D, most laboratories give a range of 30 to 100, and your PCP said you're 39, you're great. No, you're not so great. It's not enough. For MS, we believe, for MS, that the vitamin D receptor should be saturated and should be 75. Now, there are a few important things to say about that. They did a trial, this trial over here called the Benefit Trial. There was a trial where there was people on Copaxone and people on beta-seron. And during that trial, one of the side arms were people, they measured their vitamin D level. And what they found is that people had low vitamin D level converted more quickly to their second attack. So this was people that had their first episode of MS. And if they had low vitamin D levels, they progressed to their second attack more rapidly, showing the importance of vitamin D. In addition, there were several studies published within the last year showing that low vitamin D equals increased MS progression. This was a study last year, actually, which was presented at the big European MS meeting, but the actual study was done in Boston, and there have been several studies, and they clearly said that. And the title of the article is, higher vitamin D levels equate to less MS activity. So I can't stress to you enough how important vitamin D is. Now you could say, do I get it from the sun? You could. But even in Florida, even in sunny South Florida, most people are deficient. So, very important, check your vitamin D level. And then once you know the level, so people often ask me the question, if somebody's already thinking of that question, well, how much should I take to get up to 75? The answer is, I don't know, until I see your blood level. It's very important to get your blood level checked. Next time you see a physician, get your blood level checked. And once you know what your level is, then I can tell you how much to take. And some people need to take a lot. And yes, vitamin D can cause toxicity. It is a fat-soluble vitamin. It can store in your fatty tissues. And so, but how do we prevent that? We can measure the level. So we have a good way of measuring your vitamin D. B12, by the way, is a water-soluble vitamin. And people sometimes say, I take B12 and it gives me energy. Well, we can measure your B12 level too. If your level is high and you're getting energy from it, great. I can tell you that is a placebo effect, because your body sucks up B12 quite well in most people, unless you don't absorb it. Most people actually absorb B12 quite well. And once you know what your level is, you're probably okay. I want to talk about salt. We spoke about the importance of vitamin D. Here's another dietary factor, salt. What do you think about salt in MS? Should you eat salt or not? Never. No is the answer. So you should have firstly a low salt diet. For those who cook, for those who are the cooks in the family, don't add salt. Don't put salt in the food, number one. Number two, don't add salt. I'm thinking that when we come to a meeting like this, well, I can't go too far over here, I'll be off camera. We should ban salt from the table. So this is another study, what they did in these studies, and the study again presented at the European MS meeting. They measured people's salt intake, and they found that the higher the salt intake was, the worse they were doing. So each gram, so there was an average daily intake of sodium. Each gram above that resulted in an increase of three lesions on the MRI scan. And also importantly, if you look at the bottom slide over here, people had greater relapse rates. So if your salt intake was double the daily average, and many people have higher than that, there was an increase in the risk of relapses of almost 4 times greater. So here you have another thing you can do for yourself. So if you go take 2 messages from what I've said so far, if you've had enough already and you want to take a little nap, you've got to remember 2 things now. Make sure your vitamin D is good, and don't add any salt. Cut salt out of your cooking as much as you can. And there's a rare exception to that. Is maybe somebody yesterday, one of my patients said their blood pressure was very low, and the cardiologist said, eat as much salt as you can. Well, I don't want you passing out. That's not good. So I passed out because my neurologist said I can't have salt. It's not good. So that may be the only exception. Other than that, salt seems to be bad. So we know it's bad for your heart, but it also seems to be bad for MS and probably other autoimmune diseases as well. And here's what I call defensive dining. This is the way you should eat. It's the way we should all eat. This doesn't only apply to MS, it's everything. It's that you need calorie and content control. So you need to control firstly what's on your plate. We spoke before already about the importance of plants, a plant-based diet, a lot of plants and vegetables in your diet. We spoke about that. Different people have different inputs on what else is important. There are some studies now that suggest that animal protein might not be the best thing for MS. And as you know, there are many different diets that are recommended for MS. There are people that recommend vegetarian or vegan diets. Recently, there's someone who published a book called Grain Brain. Have some of you heard of Grain Brain? Dr. Perlmutter is a well-known neurologist in Naples who wrote a book called Grain Brain, as a result of which he now drives a Bentley. It's high up on the New York Times bestseller list. I think it's a little bit excessive. He says everyone should be gluten-free. So if you go on the internet, you can find many, many different things and different variations on the diet. But there is some work now suggesting that animal protein affects the bacteria in your gut, and that animal protein and dairy you should either moderate or not eat. This is something you're going to make a personal decision about. But also, calorie control is important too. It means don't eat big portions, and share the portions. Sharing. And who is the most important person to share with? Yourself. So what I say is, when you go to most restaurants, the portions are humongous. Too big. So I'm saying automatically at that time, as soon as they bring you a portion, say, look, I need a doggy bag, bring me something, I want to pack half of it away. So like if you go to get pasta, push half of it aside, put it in your doggy bag, take it home, you've got another meal. And take what you got in your plate and spread it out. I guarantee you that's going to be enough, especially if you eat slower. So when you eat too fast, your brain hasn't got the message that you've got enough food and wants you to eat more. If you eat slower, messages are going to your brain and what you have on your plate is going to be enough. And then salad dressings, especially fatty, things like that, put them on the side so you don't have to add them. And the alcohol, of course, has calories. And we talked about salt. You all know sugar is generally considered to be a toxin by many people. There are many books written about sugar, so avoid sugar. Do it in moderation. And saturated fats is another thing. Saturated fats goes way back. Saturated fats goes back years. So for some of you who've had MS for a long time, before we had drugs, we used to talk about the swank diet. And we still talk about the swank diet, and you can read about the swank diet on the internet. Dr. Swank was the one who wrote this book over 50 years ago. Originally in Montreal, Dr. Swank did this work over 50 years ago. Dr. Swank died a few years ago. He was 99 years old. He worked till he was about somewhere in his 80s. So, you know, and I think he must have followed his own diet. It's a diet that is vegetable-based. He does, in parts of the diet, allow some meat. But the Swank diet you can still read about. I've put on this slide over here other sources of information. If you're interested in your diet and MS, other sources of information. So the Blue Zone is a book about, which was commissioned by National Geographic. The China study is a book that was written about diets. The person who wrote that book was a person who was originally a farmer and went to school to become a veterinarian so he could fatten the cows and sell more fat cows and therefore make more money, and felt really that this was not healthy eating, and talked about basically a diet that's meat-free. And these are other things you could look at. The CSPI Nutrition Scorecard, it gives a score to all different foods. Anybody want to guess what the highest rated food in that scorecard is? Any guesses? Berries are high. The highest rated on their scorecard was sweet potato. And then these authors at the bottom are all very good authors. Joel Furman, we already referred to. Neil Barnard writes some excellent stuff, and Dean Ornish, you can go on the internet, read all their dietary recommendations. It's for healthy eating for everybody, and everybody with MS too. We're still on the subject of eating. Obesity. So who would think that obesity could have anything to do with MS? And here it is, very well shown in some recent studies. That one doesn't, does that one, can you read that one at all, or that one is bad? Yeah, sometimes if it's too late at night, I get my colors mixed up, I guess. But this, I'll read it to you. It says that obesity at age 20 strongly correlates with genetic susceptibility. And there were two big studies of over 1,000 patients, a Swedish study and an American study of almost 1,000 patients, in which they looked at obesity in teenagers and young people 20 years old. And they said that the obesity correlated strongly with the development of MS, especially in genetic susceptibility. What does that mean? You have an opportunity to reduce the risk of MS in your children. How do you do that? If they're 20 years old and they are obese, meaning you look at their BMI and it's greater than 27, their risk is much greater than if it's 18 to 20. So you have a risk. You can counsel them. Take vitamin D. Don't smoke. And let's control your weight. These are all risk factors that you can take. So if you have a kid that's got low in vitamin D and they're smoking and they're obese and they get MS, then you have a right to feel guilty. If they don't have those things, you have no right. It's the luck of the draw. But if they have all those things, all those risk factors, and you haven't counseled them or taken those precautions, here we have an opportunity to practice some preventive medicine. Here's an illusion that you can see. You can see two plates. Do you think the portions are identical? They are, of course, identical. That's the whole idea of this over here. The portions are identical, but look at this over here. Why would you eat more on this plate? You think, well, I don't have much to eat here. My plate is packed, but I don't have much to eat. Sometimes this is the way people will sell things. Here's another illusion I'll show you briefly. The same kind of illusion over here. If you package it differently, you're not going to know the amount that you're eating, and so they can sell you larger amounts. We're still talking about the self-help, and the many different kinds of social support that you can get, social relationships, social networks, emotional support, material support, informational support. So you can see there's many different things that are things that can help you. And so to end off the self-help section, I've put here what I call the pillars of MS, things that are very important that everyone should practice, which is vitamin D, which is becoming more and more important, which is your diet, especially low salt, and calorie and content control, avoiding smoking, exercising, support. And you can see I put two types of support there. I put support in, it's very important. Support in is what? It's what you get to help you. So it's nice, it's great if you have a very supportive family or friends or go to meetings. Support in is very important. But equally important is support out. I call that, both of these you could actually call the power of kindness. You can also do things. So you might have MS, but you can help other people. And if your family helps you, appreciate it. Showing appreciation, thanks, thank you for doing this, being kind. Can you imagine if each one of us was kind on the roads? I don't know what the roads are like here. They're probably better than South Florida. In South Florida, when you put out your signal to get into the lane, the car next to you speeds up. They don't say, go right ahead. They speed up sometimes. I mean, there are people that are kind and let you in. That's an example of being kind, being patient, being compassionate, understanding someone else's situation, and slowing down. I'll give you one other example of that issue. Is I was on a plane recently flying, and a kid opened the overhead compartment, and a cane fell on my head. It just dropped down, hit me on the head. So my initial 1 second reaction was that I'd like to take the cane and, hit him with it. But immediately, in 1 second, I kind of like assimilated what had happened, is that this was a little kid who looked about 10 or 12 years old, and he'd come on the plane with his grandfather, and he's 12, and he put the cane up and it fell out. And so my immediate next second reaction was, can I help you? Because I felt bad. I'm a grandfather, I've got little grandkids, I could be with them. And I thought, boy, I'm going to take this moment of my initial anger with the cane hitting me on the head and be compassionate and offer them some help. And so I think we all need to do this. Step back for a second, be patient, be kind. And with MS even, we can have some kindness and appreciation. Just like we're getting in, we can also help. Everybody can help somebody, believe it or not, no matter where you are. In a wheelchair or in a walker, you can always do something to show someone, well, thank you, thanks for doing that. That's one thing people like. They like it when you thank them. Everybody's happy when you say, well, thanks, thank you for helping me. People are happy to receive the thanks and not be taken for granted. So that's the end of the self-help section. Stuart, how much longer do we have there?
A long time.
A long time, good, okay. Just a summary of the land of MS again. And we're going to move on to talking about different types of MS now. So you all know classically, if you go to a meeting, they're going to tell you there are 4 types of MS, which are relapsing remitting, which can convert into secondary progressive, especially when untreated, primary progressive, and relapsing progressive. But I want to point out to you that we now know in recent years that there are earlier types of MS. And the type you know the best is called CIS. CIS stands for clinically isolated syndrome. That means your first episode of MS. You've had no prior symptoms. Your very first symptom, it's optic neuritis. And you go to the neurologist and you say, I have optic neuritis, I have tingling, I have numbness, I have whatever symptom you have. It's your first symptom. It's called a clinically isolated event. Because to diagnose MS, typically we require someone to have 2 episodes separated in space and time. So this is your first event. And in the past, we couldn't diagnose MS until you had the second event. Things have progressed a little bit now. Sometimes we can actually diagnose MS based on the MRI scan. But for the most part, we are able to say early on you have a clinically isolated syndrome, and therefore you have some risk of getting MS, and therefore maybe we should start treatment early on. First event. However, we have even an earlier stage than that. It's called the radiologically isolated syndrome. That is when the only abnormality you have is on your MRI scan. You've had no symptoms of MS. And coincidentally, we discover on your scan that you have MS. You might have migraine, you might have an automobile accident, you bumped your head, there could be a variety of other things going on, and your MRI looks like MS. So it's very early, and it suggests to us that you might be at risk for developing MS. If you have an abnormal MRI scan of your brain that suggests MS, we will tell you that, but we will not start treatment. We also need to do an MRI of your cervical spine, because if the spine is abnormal, the risk for developing MS is actually much higher than if the brain only is abnormal. But so far we haven't decided exactly how we manage these patients. We follow them along before we definitively treat them at that very early stage. I don't know, I guess the lights are bleaching that out a little bit too. Can you see that? Can anybody see this beside me? Yes, some of you can see that. Okay. What this says is that there are risk factors. So if you have presented with MS and you say, what are my risks? How is my MS going to be? I can't always tell you. There are some people that start mild and the disease transforms and becomes aggressive. Some people have a bad early symptom and then they don't progress that much. But there are these 6 factors that we would look at, which is firstly the age at onset. Greater age of onset suggests more progression. Symptoms at onset are important too. If your first symptom is optic neuritis, that is a good first symptom. Whereas if you have a spinal cord symptom where you have trouble walking maybe and lose bladder control with the first episode, that's much more troublesome. And then what your MRI looks like is important too. The worse your MRI is, maybe the worse the outcome will be. And then the interval between the first and second attack, and the frequency of the attacks in the first few years, and how well you recover. And the more of these that you have, the greater the risk, and therefore the more urgency that there is for treatment, or maybe being more aggressive early on. So these are some risk factors that help us try and make a decision about how to treat you. Because when we decide how to treat you, we're trying to personalize the treatment for you. We're trying to pick the best treatment that's for you as an individual. What's best for you in terms of maybe your gender, your position in life, or is it a childbearing female? Is it a 50-year-old male? Do you have other diseases? Are you diabetic? Do you have heart disease? All these other things. Okay. This is just showing you about the MRI, the importance of the MRI scan. And so what this shows you is that if you have a clinically isolated syndrome, so now you've had optic neuritis, and we look at your MRI scan and we say, can we predict from your MRI scan what your risk of MS is? And what this says is that if your MRI scan has 0 lesions, you have a normal brain scan, you still have a risk of developing MS over the next 10 years, but it's only about 20%. If you have even 1 lesion that looks like an MS lesion, even 1, it doesn't matter whether you have 1 or 10 or more than 10, your risk for MS is about 80%. So normal MRI scan, low risk. Abnormal MRI scan, 80% risk of having more MS problems, more MS lesions at least, over the next 10 years. However, the number of lesions affects this. This is a disability scale over here. On your right-hand side is a disability scale, and you can see the disability going up. So the more lesions you have, the more likely at the end of 10 years you're going to have greater disability. Therefore, we should maybe be more aggressive early on. I'll skip that one. It's also to do with disability. What this one basically says is that we try and stop the progression of the disease as early as possible. But when people reach a certain stage of progression, then the progression in everybody goes at about the same rate. So this slide also goes to the fact that we want to start treatment early. So what you'll see over here, well, I guess once I've started talking about it, is we have a disability scale called an EDSS, and there's a cutoff here at about 4. And you can see this person over here took about 5 years to get to a 4. This person took 25 years to get to a 4. But once you get to a 4, everybody's slope is the same. Everybody starts to progress at the same rate. Again, more evidence that we should start treatment early on. Now, what about if we don't treat people? Is there such a thing as benign MS? There is. 10 to 20% of people have benign MS. What does that mean? That means that 10 years after their diagnosis, we look at them and they pretty much have minimal or no deficits. Can we predict that at the beginning? A little bit. I mean, if your scan looks very benign, you have very benign symptoms, we might say you might be in this group. Still, though, we don't have the crystal ball and we don't know who's going to be in this group. But at 10 years or so, we can look at this group. Now, they've studied this group of so-called benign MS at 10 years, and they actually looked at them at 10 years later, 20 years, and 1/3 of them progressed over the next 10 years. So with MS, this is a disease we have to constantly be vigilant. It's called relapsing and remitting MS. But it's not the same as cancer. If we say you have cancer and you're in remission, your cancer is, as far as we can tell, there's no sign of cancer. But if you have MS and we say you're in remission, it doesn't mean there's no sign of MS at all. It just means it's not active at this point. But if we do a brain scan sometimes, surprisingly, you might have no symptoms and your brain scan could be active. So with MS, we constantly have to be on the watch. Some people have what's called malignant MS. They rapidly progress. There's about 5% of people that have that group. Finally, we know from studies that were done before we had treatments, 1990 they did a very big study at Mayo, and they said, what happens to people that have MS, relapsing remitting MS? And they said 15 years after the diagnosis, 50% of people have progressed. 50% haven't, but 50% have progressed in 15 years. Now, if you think about the fact that most MS starts at a young age, 20 to 40, and now you've progressed within 15 years, you're now 35, 50, you're still young, and you've progressed, this without treatment. And at 25 years, 80% of people have progressed. So now you're 45 to 60, and 80% chance of progression without treatment. This is from studies done in the days before the treatments. And this is what the treatments have afforded us. The opportunity to change the course of the disease. Cure, we don't have the cure yet. Hopefully that's soon. If that happens, then we'll have a much briefer discussion. But this shows us what we've done and what we need to do and what happens if you don't start treatment. I think in the last few minutes, is that 5 minutes or yes, Stuart? All right, so this is the exciting slide. I put in early, I could start with this. You could start in the classical MS discussion about the medications we have for MS. And so what we're talking about is, if you think about, again, I said beta serum was the first drug introduced for MS in May 1993. So imagine if we were sitting here talking in April 1993. What would we be talking about? We didn't know about vitamin D and diet and things like that. It would be a pretty boring discussion. We could talk about spasticity and the bladder and a few things like that. We'd have none of these medications to talk about. Nothing over here. So this shows you all the drugs that have been approved for MS. And Copaxone was recently approved in a new formulation. You could put it down over there. Extavia is the same drug as beta-seron, interferon beta-1b. So if you count these, as I said, there's 1, 2, 3, 4, 5, 8, 9, 10, the new formulation of Copaxone, 11 different agents approved for MS. And look what's happening over here. Look at these up here. There potentially could be 4 more on the horizon. These are potent medications for more active forms of MS. We're not asking the FDA to allow us to approve alemtuzumab, which is now called Lemtrada, which was turned down by the FDA recently for reasons unknown to most MS neurologists. It's a very effective drug for certain types of MS, for people that have more active disease. And we're saying to the FDA, and we would like you to help us, say to the FDA, this is for certain people with MS. This is not for someone that has mild disease. Let us and let you make the decision, because people overseas in Europe or Canada or Australia or even Mexico have this drug approved. And then there are some other drugs over here, some other potent medications that you can see on the right top hand, which are going to be approved. So in the next few years, if we're talking, we may have 15 different medications that we could talk about for MS. And here's some experimental medications. So these are drugs, other drugs. Some of the drugs that I showed you in the previous slide are already in advanced clinical trials and near to completion of the studies, and hopefully, if the studies prove to be effective, for approval. That's where some of those drugs in the prior slide are. But on this slide, you can see other things we're looking at, and I'll point out this one over here, siponimod. Siponimod is also in the trial, abbreviated. If you look it up, you might look up BAF, B-A-F 312, BAF 312. Why is that interesting? Because it's in trial for secondary progressive forms of MS. So some people often ask me the question, I have secondary progressive MS, what's there for me? As you know, the FDA has not approved anything for secondary progressive MS except Noventrone, which is a toxic chemotherapy drug that nobody uses anymore. So this drug now is in trial for secondary progressive MS. You can see by the name, it's similar to fingolimod, which is, of course, Gilenya. Then there is a T-cell vaccine that's under trial, where they take your own blood, and they modify the T-cells and inject them back in to form a vaccine. So this is in trial right now. And then there are more studies going on at the bottom with vitamin D And statins, even there's some studies recently that show that statins that you take to lower your cholesterol could have some role in MS too. Also under study. Recent positive studies suggesting that in people with progressive MS, statins might slow their progression. So there's a lot of work still to be done, a lot of other experimental medications. This is our goal of treatment. Whatever drug we do, we have the same goals of treatment. Every time you go and see the neurologist and you are evaluating your medication, there are two situations where you're evaluating your medication. The first is when you start the medication. You're newly diagnosed and you're starting a medication. And the second situation where you need to do these things is where you're switching the medication. And you say, my medication is not working anymore for me. I need to switch to a different medication. And these are the considerations you have in both of those situations, starting and switching. I want medications that reduce the frequency of my relapses, that slow the progression of disability, and reduce MRI activity. Those are the three things, the most important three ways that we measure how you're doing every time. Every time you go to the office. You report your relapses. I examine you. I can see if there's some progression or disability. And we look at the MRI scan. We can do those every time. You should do those. And this is how we know if your drug is working or not. And make the decision. You're going to stay on this. You're going to change. These are the same considerations we're going to have every time. So we're going to look at these things about your medication. How are we going to pick a medication? What are you going to use to pick the medication? Is the medication safe for me? Does it have efficacy? That is the same as saying, is it effective? Is it working for me? How well is it tolerated? These are the things you look at every time with your medication. Is it safe? Is it effective? How well is it tolerated? What tolerability issues could there be? Could there be flu-like symptoms or reactions in the skin? And then there's some other things you might want to know about. How do you monitor for this medication? What do we have to do to follow up? Do we have to see an ophthalmologist? Do we have to monitor the heart? Do we have to check the liver? Do we have to check the blood? And the same thing applies to screening. What do we have to do to get onto this medication? Do we have to check our heart or our lungs or to see if we have TB? What are the screening requirements? And also important is cost and convenience. Convenience, obviously, and cost is the insurance company forcing us sometimes. They will pick and choose and say what drugs they prefer. It doesn't matter what we prefer. They sometimes force our hand and make us change our plan of action. So these are all things, and finally risks and benefits kind of in a way summarizes everything else you've looked at over here. But when starting a treatment, these are the things you think about every time. Safety, efficacy, tolerability, cost and convenience, monitoring and screening. Every time we think of those. I'm going to kind of wrap it up in a minute over here, and I'm showing you these things. This is the last slide, and showing you the complexity of this. So when we put you on a medication, this is all the things we should be thinking about. There are other issues that, for example, personal issues, pregnancy issues. How does the drug work? What is your preference? You might say, my neighbor or my relative takes this medication, or I've read about this. There's many other issues that come into the decision making. We talked about this. When do you switch? The ways we measure how you're doing. Again, relapses, what you report, disability is my report, and the MRI scan. We look at these and decide if the medication is working for you or failing. Are you breaking through? How adequately is the medication working? I'm just quickly going to, this is the last thing I want to show you over here about more things that we're thinking about. When we're personalizing the medication for you, things we might be thinking about. How severe is your disease? What's your medical or family history? What's your risk tolerance? This list is long, and I don't expect you to look at it. I just want to show you all the things that have to be taken into consideration. And your medical history is important. Do you have liver problems? Do you have depression? Do you have heart problems? Do you have eye problems? Do you have a history of infections? All these things are things we have to think about when we're picking the right medication for you. So it's very important. I think I'm going to end with this slide, and the point I want to make about this slide is to make your visit to your neurologist important and valuable every time you go there. And in my office we do this. We have a list that patients fill in every time they come in. And it asks several things. It says, number one, what is the list of your medications? Every time I want to know that. And sometimes people write same. What do you think same means? Only one drug change, maybe. You've got to write your medications down. We want to know about that. What are you taking? Because things interact with each other. I want to know your medications every time you come. If you have a list that's typed out that you carry with you, great. Write down your medications every time. Write down your supplements. It makes your visit valuable. Number two, I say, write down your new symptoms. And I have a section for current symptoms. And I list all the things that can happen in MS. Are there sensory symptoms? Are there motor symptoms? Are there bladder symptoms? Is there fatigue? Do you have memory problems? I have them all listed there, and I say circle them off. Write down your chronic symptoms, but most importantly, why are you here today? What are your new symptoms? And part three is questions. Write down your questions. What's the purpose of the visit? It could be routine checkup. That's the best one. I feel great. It's my annual visit. I feel great. That's the visit I like. But it may not be that. It might be bladder problems or fatigue. So if you see the neurologist, and I know you have some excellent neurologists locally, but that's, to me, the most valuable thing. It makes your visit much more valuable. Bring that list. I look at it in 1 second. I look at your medications, your supplements. I know your current symptoms. I know your old symptoms. And I see your questions. And I say, okay, in 15 seconds I can look at this, and your whole visit is now valuable. We can spend our time discussing important issues and not for me to drag it out of you, because that's the worst thing. How many times that I've stood at the door of my office and said, well, good to see you, I'll see you in 6 months. I said, I forgot to ask you about my bladder problem. A bladder problem is not a 1 second discussion. It's complex. And all things like that need some time. So, but if you put them down, we can time our visit and make it valuable. So that's why all these things, I want to know about your medical history. People don't write something down. They don't put down their blood pressure medication. I want to know about that. You have a blood pressure problem, or maybe you could be restricted from certain drugs, or you should be more careful monitoring. So that's why your medical history is essential, and all the information you give us is very important. It's part of the self-help, what I talked about right at the beginning. You help me, you help yourself by giving us as much information as possible. So on that note, thank you for listening.
Thank you, Dr. Steingo. So, for those that don't realize it, when he's telling you to bring him questions, he's talking about bring your doctor those questions. Bring your doctor those lists that he was just talking about. Not that we expect you to go down to Pompano and see Dr. Steingo. All right, so the next portion of this is the Q&A. And I need you all to help me lose weight. I need you to run me around this room. You guys are going to use the mic. Dr. Steingo is going to come down and he's got a mic. And I'm going to run around the room and take your questions for whoever wants to ask them orally. If you want to write down your questions because you're afraid to ask it, then just write it down and give it to either me or Michelle or Jill back there. You can run around and they can run around also and get your questions from you. Okay, who's first? Oh, I saw a hand over here. By the way, you're not being videotaped or video recorded. You're only hearing your voice, all right? That's it.
My question is actually for the first doctor that came up. During a different discussion at one of these meetings, I asked the question, what was the chance of my passing on MS to my children? The answer that I got was 98% he's probably not going to get it, or my children probably won't get it. While you were speaking, you mentioned that our children are at higher risk. So what exactly is the answer to the question?
The answer is that both answers are correct. So if he said that your offspring have a 98% chance of not getting MS, your neighbor's offspring have less than 1% chance of getting it. So if we're saying your kids have a 2% chance of getting it, the neighbor's kids have less than 0.5% chance of getting it. So the risk is increased. So we're saying it's not a high risk because they inherit susceptibility, they don't inherit the disease, but it's a higher risk than someone that doesn't have MS. That's what it comes down to. And now what we're learning, most important message that you have to take home, if you have children, brothers and sisters, is the message, the things I spoke about tonight. Vitamin D is important. Obesity to control. All these important factors are things that you can now prevent. Smoking, if you have teenagers, don't smoke. Learn about show them, give them the article. Look it up on the internet, smoking and MS progression. So you can intervene and you can say, you have a risk. I have MS, therefore you are at increased risk. Doesn't mean you're going to get it, but your risk is increased. Now take care, do all these risk factors so you can reduce your risk further.
Next question's over here.
This is for you still. You talked about genes. I have multiple sclerosis, okay? What's the possibility of looking at my genes? And again, this is something might be off the wall, okay? But again, then you take another person that has MS and look at the genes that they have, okay? And then see what the comparison says. And basically, you know what I'm saying? I mean, it's basically comparing them two together and saying, all right, this is what they have in common. What is the possibility of doing that? And are they doing that?
Yes, they are doing that. So the answer to your question is very high possibility because they're doing it already. So there are, at the University of Miami, the gene department at the University of Miami, the genetics department is superb. It is excellent. It's been funded by the MS Society too, and they are doing genetic studies on people with MS. They are particularly interested in people that have more than one person in the family with MS. But anybody with MS that wants to give blood for them to study, to keep in their bank, they study the genes. They look at the genome, which is your gene pattern. They study and try and see what genes are prevalent in people with MS. And going forward, can we differentiate the type of MS that you have by the genes? Can we look at your genes and say, well, you have this kind of MS. Is there a pattern that's emerging in different people? So the University of Miami is studying that. And in fact, I don't know how far they travel, but they in South Florida, certainly, they'll send out someone to people's houses to collect their blood, to keep it in the gene bank. And they might even come as far as Orlando. I don't know. You could find that out. So at the University of Miami and in California as well, Dr. Hauser, these are excellent genetic studies that are ongoing and have identified to this point many different genes that are more prevalent in people with MS. So right now you can't localize it to one gene. There are many genes that are involved. And we're still studying that.
All those genes, you can basically see what is similar.
Well, as time goes by, more and more, when you get more and more people involved, you might be able to localize certain facts about it, which people are more likely to get it. And more importantly, can we predict from your genes what drug you're going to respond to? We can look at your genes and say, well, looking at this pattern, this person is likely to respond to Copaxone, but not to interferons. Or this person can respond to something else, or this person might need a different kind of treatment. So going forward, these are things we're going to be looking at, or they're looking at. So there are a lot of genetic studies that answer your question, but there are so many genes that are increased in people with MS. The patterns are still being identified.
I got one more question. Dr. Valerie, is it possible to remap in your mind? And if it is it possible of improving memory?
I'm not quite sure remapping. I'm not quite sure how I would address that piece.
Let's put it this way. I mean, if I tell my toe to move over and over and over and over and over and over again, okay, that toe is going to move eventually because my brain is telling that toe to move. Okay, eventually it's going to hopefully my mind will remap itself to move that toe. And then the same way is basically, if I tell myself and I keep telling myself my memory is going to get better, it's got to get better, it's got to get better, and just have all the heart desire to, and it goes on and on and on. But is it possible of remapping your mind to improve your memory?
When we look at memory functioning, it is not the case that we're improving the memory per se. What we're able to do is to identify strategies that are helpful in supporting the memory, such as use of smartphones or other strategies that we can use to eliminate distractors in our ability to learn new information.
Sorry, I'm taking over again.
Yeah, last one.
Okay, no problem. But that's counteracting the symptoms. I want to be able to cure, or to make better.
Well, making better is absolutely the goal. Cognitive rehabilitation does improve functioning. But for example, with memory, if we assess someone's memory before learning strategies and we assess their memory after learning strategies on standardized neuropsychological measures, the test scores do not change. What happens though is that you learn a strategy that permits you to effectively go to the grocery store and to get all the items that you need. Or you learn strategies that permit you to recall, on my way to the store, I need to stop off at the post office. And afterward, I need to get back in time to get to the airport to pick up my buddy. So it's the functioning that is improved by means of the strategies.
Okay. That okay? Okay.
The articles behind you, the first one, the miracle marijuana and the research, I don't know what your take is on that, but what symptoms would it be treating? Because I see that it would just maybe make the person more fatigued.
Who are you asking? I'll answer. So yeah, in this, firstly, medical marijuana in the state of Florida, as you know, of course, is not approved. So if I prescribe it, you'll be visiting me at the local jail. Unfortunately, which is, in fact, in our local newspaper in Fort Lauderdale, the Sun Sentinel, there was an article just 2 days ago on the front page about prosecution of doctors who want to prescribe medical marijuana. So we're very antiquated with that, because you could go to Colorado and get marijuana for medical purposes if you want to. So what marijuana has been shown to help with MS is pain and spasticity. Those two particular symptoms seem to stand out that marijuana helps. On the other hand, they've also studied MS patients and shown that marijuana use on a regular basis affects cognitive function. So you might be pain-free but not so smart. That's what it could amount to. So what you can do is do a balance. I have patients who smoke marijuana, and what they do, for example, is they just smoke it at night. So they say it helps their pain and it helps their spasticity, and they get a good night's sleep. But they don't do it all day. So they have time, they're not abusing their brain all day. So I think if it became more and more allowed, and if more states allowed it, we could get more studies done. But that said, there are studies going on. Particularly going forward, what's going to be important is to use marijuana derivatives, not just marijuana, use cannabinoids, which are marijuana derivatives that don't make you addicted or high, but yet affect neurotransmitter pathways, so they could help your pain and your spasticity without making you high. So going forward, these are things we're hoping for. But for right now, pain and spasticity seem to be benefited.
Thank you.
You're welcome.
When you go and get a normal blood test, does your vitamin D reading come out of that and your vitamin B12, or do you have to request that specifically?
Right, so when you get a routine blood test, you would not get a B12 and a D. You would specifically have to make sure that your physician writes B12 and D. Separate tests, separate codes, they have to be requested. Sure.
Hello, I have a question. You mentioned sodium, salt intake, not to do too much of it. I'm not a salt person. However, this summer, I guess my sodium was so low that my neurologist was like, you really need to bring your sodium up. And I'm like, how do I do that? Add salt to stuff. And I'm like, I don't like that. So obviously, I'm not thinking they were looking at it as a neurological thing, maybe some other reason why my sodium needed to come up.
So there are a few answers to that. So as I mentioned to you, when they did this study, the way they measured salt was by salt intake. It wasn't by measuring the blood sodium level, which is a fairly narrow range. In these people, they actually measured the amount of salt that they had in their diet. And for example, let's say if the normal intake of salt in the diet is 2 grams a day, the normal recommended amount, if you quickly look at the things you eat, you'll see how quickly you get to that amount. It's staggering how much salt some things have, how much sodium. So I would say when you buy snacks, and you buy any food, look at the amount of sodium in it. Buy low sodium products, much healthier for you. But there's enough sodium in the rest of your diet that usually your sodium level in the blood is good enough for most people. But in people that have more than 4 grams a day, their risk for relapses was 4 times higher in that study. But if you have low sodium in your blood, which is different from what they measured, which was the salt intake, if your sodium is too low in your blood, there's a normal range, say 130 to 135. If it's 120, you could have seizures. And you could have neurological problems, seizures, confusion, and things like that. So if your sodium is too low for other reasons, you might be on a diuretic, you could have medical issues causing it to be too low. It's usually a medical problem that makes it low. Then you might need sodium, like the example I gave of the one patient I saw who had a very low blood pressure and would faint sometimes from standing up. In that situation, you may need to take the sodium. So you've got to weigh it up with your medical problems. It will be an unusual situation where the sodium is low like that. Most people have normal sodium in their blood. But if it is low like that, then there could be an exception where you need to take a little more sodium.
Okay.
You're welcome.
Put your hand up higher.
Okay?
Halfway through the stick.
Oh.
There you go.
Okay.
All right. Who on this side of the room has questions? M and J first. No, you do.
No, I don't. Going back to the blood testing from Miami, when and how can we find out what's going on with that? Because I know I gave blood a year ago or something when this started, and how do we find out what's going on with that?
I mean, I'm not part of their study. It's the Houseman Institute. I'm sure you could call them. We could look up, if somebody has a laptop here or something, we could look it up and I could get their numbers, or I could give it to Stuart. Do you have their any information about them on your web page or anything like that? We could just put on the information about contacting the Houseman Institute for the genetic studies.
I can get her the information.
Yes, we'll get that information for you. The informant is standing behind you. We'll get it for you.
Yeah, she was really big. I gave a part of it too, and I didn't need their rep, but she was really big on the genetics. The lady in Miami. Because I have 2 cousins and 1 aunt.
We can't hear you, so we're going to have to wait till we get there with the microphone.
Yeah, right now, so you have family members that have MS, and they're particularly interested in that to see if there's patterns that run through families. So they're very, but they're interested in all of it. But right now, it's mostly a gathering of information. And they have this massive computer that analyzes all this stuff, and they're looking at all kinds of different situations to try and see if they can find, patterns of involvement. I'd say it's still early, but we're getting information. The more people contribute, the more information there is, the more we're going to learn about genetics.
I want to let you all know I had the honor of being invited by University of Miami one time to their genetics program. And it's just phenomenal what goes on down there with the amount of research that's happening. And they showed me their little discs, their little glass trays, and there's like 40,000 specimens on each little half-inch piece of glass, and it's just incredible. And how they store these specimens and what they're looking for, and they showed me a lot of the diagrams of what they're actually looking for to see what's causing what. It's just very detailed. I'll get more information about it, and we'll get it onto the internet soon.
Doctor, can you go a little bit deeper on the salt? And as an example, does the salt block the absorption of any chemical on the cell, or how does the salt affect directly the MS?
Yeah, so the answer is we don't know the answer yet. It's the same as vitamin D. We've known for a long time that vitamin D was very important, but it's only in recent years that we've recognized that on the cell surface there's a vitamin D receptor, and that's where vitamin D is working. So we recognize that now. And with the salt now, these studies are only published in the last couple of years. We're not sure exactly how it works. It's clearly something to do with the cell itself, with the environment that the cell is in, but we don't understand why that is important for the immune system. We've known about salt for many years with diuretics and with heart disease and high blood pressure. So for many years people said don't have a low salt diet if you have high blood pressure or heart disease. Now we're understanding it's also important for the immune system, but the exact mechanism, we still don't know that. We do not know the mechanism. Only the fact that it is very important, but not the mechanism.
So somebody gave me a question to ask him. What about, forget about adding salt to the diet, but what about salt that's already in foods? What do they do about that?
Well, you need to eat. So I'm saying you need to be looking. We spoke before. I said one of my slides talked about calorie and content control, and so we're saying you need to look at what you're eating. If you like snacks, make sure they're low sodium or salt free. And yes, maybe that doesn't taste as good when you start, but after you've done that for a while, you adjust to it. And so that's what you need to do. Cook with the least amount of salt possible. Don't add any extra salt. If you're eating and the food's not that tasty, we need to find other things to improve the taste of our food. We need to stay away. We need to avoid adding salt and use as little salt as possible to cook it. When we eat foods, look for the low salt varieties. We just have to become more conscious of what we're eating.
Question here.
Is there a difference between Himalayan salt and regular table salt?
I think any kind of salt, which is basically sodium chloride, this would apply to. So in the study, they didn't look at that. All they specified in the study is they looked at salt intake. So they didn't specify what kind of salt. I think as long as it's salt, they've got the same risks.
By the way, everybody's set on the MS and relationships. You have no questions. You all have a perfect relationship. You have no questions for the neuropsychologist? If you do, just raise your hand.
Okay, I want to ask the question you was talking about. Someone had asked a question about the marijuana thing. Since I never even smoked a cigarette, isn't that pretty much, can't that cause us to still have like things people get when they smoke? You know, isn't it? I don't know how that works.
Yes, I mean, marijuana can cause whatever problems that we know about. The main problems with marijuana are psychological and mental issues.
Okay.
I don't think
so
anybody's...
so it's no different that, so this kind in Colorado, is no different than the other one, is it?
Well, they have some different varieties over there. They have people over there that are obviously now opening factories and businesses and not only producing regular marijuana that you smoke in a joint, but derivatives of cannabis. They're called cannabinoids, which are different, which don't make people feel as high and which might work on transmitter pathways and not have all the bad effects of smoking it. So they have it in cookies. You can get what? I think you can get cookies of cannabis and all kinds of products like that. So going forward, this is going to be the future. It's not going to be smoking joints with those kind of effects. It's going to be using derivatives.
What was that called again? She asked what that was called.
Cannabinoids. Marijuana is cannabis. So the drugs that are derived from it are called cannabinoids. Spell cannabinous and then add oids. Like droids, oids.
I got it.
Take out the S and add oids.
I got it.
Stuart's got it.
Wait, question here first.
Okay, I have a question on relationships. I am a person with MS. However, I have a really hard time getting my mother to understand sometimes when I have an exacerbation that there are certain things she needs to let me figure out and not panic. I have to tell her a lot of times, when you panic and you scream, it startles me and it stresses me out. How do I nicely let her know she needs to calm down? I know she's a mother. Everybody tells me that she's a mother. But any suggestions on how I can go about nicely letting her know, calm down, it's okay. I'm thinking about it. I got to process this by myself, or not by myself, but I need to figure it out because I do live alone.
Yeah, exactly. This is the piece of balance that I mentioned several times. A parent, their role for a very long time is to be the one who takes care of things. And whether it's an adult who has children, this is the same task. That is, when is the time that it is necessary for the development of the little kid that they do it on their own. And when the individual with MS receives some care or support by their parent, this is very challenging. It's challenging for these relationships regardless of the directionality. So if it's the older parent whose functioning is now impacted by whatever condition, who's receiving some care from their adult child, these reversals or alterations in the expected pattern of relationships are very challenging. A couple of suggestions that I would have. One is that in the moment when it's occurring may not be the best time to get this addressed. So a direct communication and conversation about this at another time is probably a good place. There are a number of materials that are available for the unaffected persons in our lives to give them some education about what's helpful, what maybe is doing too much, and thereby is not so helpful to the person affected. A very common type of circumstance that you're talking about. And like folks have said to you, it's your mom. You know, she's attempting to help. It's for the best of reasons. But again, a conversation when you're not in the moment is probably the best way to go.
Okay, next question's back here. We're going to get 2 questions here, and then I'll make it up front.
I have a question for each of you. Dr. Steingo, one of your slides showed a progressive scale, and you said that once people get to a particular point or number of years, the rise in progression is the same. Do you think that is cognitive or physical? If someone has physical disability, does the physical disability get worse, or are they likely to get cognitive disability as well?
So that scale is a physical scale. It reflects walking predominantly. It's called the EDSS scale. We use it in all our clinical trials. Every drug that we've spoken about, all 11 agents that are approved, everything you take for your heart or your lungs or any other condition, all go through clinical trials. And for MS clinical trials, we use the EDSS scale, which is predominantly a walking scale. And that scale basically says when you start to have trouble walking, then the acceleration can be very similar in everybody, no matter how long it took you to get there. So if you start to have trouble walking in 25 years, your rate of progression could be just the same. All of a sudden, you start to get worse at a more rapid pace. So we want to stop you getting to the stage 4 on the EDSS scale. It's a physical scale. On that scale, cognitive function plays a very small role. But probably the same thing would apply. You know, we didn't even talk about, there are such things as what we call invisible symptoms of MS. Right? How many people have been told, you look so good? Yes. The MS Society puts out a booklet that says, well, you look so good, or boy, you look so good, or wow, you look so good, or something like that. Wow, you look so good. But inside, you don't feel so good. You might have fatigue. I can't see if you have fatigue. I can't see if you have pain. You could be crazy. You could be psychological. You could be looking for drugs. You could have other symptoms. You could have loss of memory. Do you really have loss of memory, or are you just lazy? You don't want to work anymore. Disability sounds nice. So there are hidden and invisible symptoms of MS, and cognitive problems are one of those. They don't come big in this scale, but they're very significant symptoms. So probably just the same as there are physical problems going on, the cognitive symptoms, which for many years have not been well recognized and ignored to some degree, are very important symptoms. But they're not part of that scale. That scale was predominantly a physical scale, in answer to your question.
That leads me right into my question for Dr. Masden. Do you suggest, or what are your feelings about anybody with MS or everybody having some neuropsychological testing to use as a baseline for their cognitive abilities?
Neuropsychological assessment can be very helpful in identifying, you mentioned baseline. Some folks have impact that increases as time goes by in terms of cognitive functioning. It can be helpful to identify the types of difficulties that an individual might have. Neuropsychological assessment can be expensive, so unless there is a clinical indication, that is, there is symptom complaint that is presented to the treating doc, it would not likely be covered by insurance. So screening everybody who has the diagnosis would not likely have great utility and would not likely be covered from the economic standpoint. Some of the things when we look at neuropsychological assessment is that we would look at all areas of functioning, so attention, memory, psychological functioning, identifying if there are difficulties, what they might be due to. Executive skills, planning and reasoning and judgment can also be impacted. And we know that one of the benefits of assessment is to identify the various factors that might account for that. MS being one of them, obstructive sleep apnea, pain, other sleep disruption, depression, are all additional areas that could be comorbid or go along with the MS that might themselves have bearing on the symptoms that an individual would have. Yes, it's helpful to have neuropsychological assessment, but then again, I am a neuropsychologist. Yeah.
I want to add something just to what you said, which is that sometimes, because it's hard to get, it might not be approved. If you complain of a memory loss and we do a test just to show you have memory loss, it might not always help us, because I'm going to tell you maybe the same things. Go and join Lumosity, or do crossword puzzles or Sudoku, or do something to keep your brain going. But there's one time when memory testing is crucial. That's when you're applying for disability. If you're applying for disability and saying, I've got a memory problem, and I write that down in my report, Joe has a memory problem, they don't care about that. We need to document it. That's when it's important that we send you to a neuropsychologist, and it's documented that what your deficits are, that you have executive problems or attention problems or perceptual problems. It becomes crucial to identify and document it. So when we can document something and put it down clearly stated, it's greatly helpful when you apply for disability.
And unfortunately, sometimes the evaluations that you might be sent to are relatively cursory, and they might not pick up on subtle but very compelling challenges that an individual might have, that are, again, sort of the silent, invisible symptoms that without detailed neuropsychological assessment might be missed, like issues with executive functioning, planning, reasoning, sequencing, flexibility. Most standard assessments would not include an evaluation of those skills.
By the way, for those that don't know, our program that we're doing here on June 21st, we're going to have a person talking about neuropsychological testing for the disability claims, and we're also going to have a disability attorney specialist that's going to be coming in from out of town to talk with you all about the disability laws.
Thanks. Dr. Steingo, I had one quick question regarding the vitamin D. My understanding was that the D3 was for better absorption. So is that probably the better of the vitamin Ds to take?
Yes, you're correct.
Okay.
That was easy.
I'd like to ask a question in regard to the genetics. Emma, really very little was known about MS until, what, 30 years ago, something like that. As far as I or any of us are concerned, our ancestors could have had MS, but we wouldn't know that because of the testing and the knowledge not being available at that period of time. And as far as the testing that is going on now genetically, you were saying that approximately 2% of our children may have a predisposition for MS if we have it in ourselves and in the family. But what I also wanted to ask was, what about other autoimmune diseases? Could that predisposition be caused not just from MS per se, but other autoimmune diseases and just manifest itself as MS or some other type of autoimmune disease? Not specifically MS to MS to MS to MS or other autoimmune diseases exactly as they are, like what's the other one? You mentioned it before. Arthritis, rheumatoid arthritis. Couldn't rheumatoid arthritis come into another generation as MS?
So you asked many questions that we could spend like the next hour. You all have time to stick around here, but I'll summarize them for you basically. So in the first part of your discussion, because there were many items, the first part, MS was originally described 150 years ago by somebody called Charcot, who was a very famous neurologist that described 150 years ago many different neurological diseases. So it was described 150 years ago. It was first called disseminated sclerosis 150 years ago. But you're absolutely right too, that we didn't understand MS much better until 30 years ago, because the huge advance in diagnosing MS was the MRI scan. That allowed us to diagnose MS. And of course now with modern techniques, we're much better able to understand it. That said though, there is no diagnostic test for MS. I can't do a blood test like I can for lupus or rheumatoid arthritis or Graves' disease, which are other autoimmune diseases, to diagnose them. I can diagnose those with a blood test. I can't diagnose MS with a blood test. And there are many conditions that mimic MS. So when I see someone that has potential MS, I have to do blood tests to make sure they don't have lupus. Because guess what? Lupus is an autoimmune disease that can affect the brain and the heart and the lungs and the kidneys and other organs. It's much worse than MS because many more people die from lupus than die from MS. So if someone has lupus, they could have manifestations and a brain scan that looks very similar to MS. And they could have both diseases. Because if you have MS, you have a higher risk of other autoimmune diseases too, as do other family members in the genetics. So autoimmune diseases in one family member, it means other family members are at higher risk, especially other female family members. These things happen. Therefore, we need to rule out all the MS mimics as well. But if you have one, you're at higher risk for others. And not unusual for people with MS to have Graves' disease and sometimes other diseases like lupus, or for somebody in their family to have that. One of the commonest autoimmune diseases associated with people with MS is Crohn's disease. It's very common for people with MS to have Crohn's, or somebody in their family to have Crohn's. But all the others may occur with increased frequency too. Does that cover most of your questions?
Okay, we have time for two more questions. I'm going to take one here and one over there.
The lady in your discussion, you mentioned the Americans with Disabilities Act. I'd never heard of it prior to tonight. Would you mind explaining a little bit about that to me, please?
Yeah, absolutely. The Americans with Disabilities Act is intended to be protective of the rights of individuals who have disabilities, with disabilities being very broadly defined. Physical disabilities, cognitive disabilities are covered. And what the Americans with Disabilities Act does is to ensure equal access by way of law to services for individuals who have a condition that falls under the definition of disability. For example, some simple things: curb cuts. People who are using assistive mobility devices without curb cuts have challenges in getting up a curb. So under ADA, there would be curb cuts. Public facilities are required to be accessible by persons who are using mobility devices. Rules that govern the width of a door, or the number of restrooms or parking spots that are available at a public facility is mandated by federal law. Under ADA laws, an individual who is in the educational system, who is in the workforce, is entitled to accommodations that could include, again, depending on what the condition is, a whole variety of things. Additional time in the school system for activities, supports of voice to text, for example, would be another example. Someone who has a condition that results in fatigue might mean that they are entitled to periodic breaks. The process typically would be that the condition is identified in a work setting. It is the employee who self-identifies having a condition that they feel might be covered under ADA, medical documentation, and then what would be considered reasonable accommodations is the term, are areas that are, again, federally directed for public facilities or that receive federal funds. That's a short description, but there have been a number of revisions, and again, there is law that is protective.
I can Google it and it'll come up?
Absolutely, yes.
And you can come to the meeting in June and get all those answers too. All right. So our last question, and by the way, for anybody else that has questions after this, you could send an email to me and I'll send it to one of the doctors that the question pertains to.
Can you go one step further on the statement you were talking about Crohn's disease? And you said a lot of people with MS have it or get it. So I know that that's kind of like related to the digestive kind of sorta and bowels, and I'm not a doctor.
Yeah, no, you're right. I mean, Crohn's disease is an inflammatory condition of the bowel. People get diarrhea, abdominal pain, things like that. And I said MS is associated with an increased risk for autoimmune diseases. And one of the common autoimmune diseases that's seen more commonly in people with MS than people that don't have MS is Crohn's disease. That's what I was saying. It doesn't mean that you have a high chance of getting it, but you have a higher chance of getting it than someone that doesn't have MS.
Does it have anything to do with the liver? Like the liver, does it elevate it?
So Crohn's disease typically involves the gastrointestinal tract, but sometimes can affect other organs. But most commonly it's gastrointestinal tract that is affected.
Thank you.
Diarrhea, abdominal pain, those are the main symptoms.
Okay, so how about we give everybody a round of applause here? Yeah, you could thank me as well. Thank you for coming down, both of our doctors, and we hope to have you back again in the near future. Again, we want to thank our sponsors. Again, we could not do this without they giving us the funding that we need to get to provide these kind of programs. And we just want you all to know this as well.